it's recommended that any of these combination therapies like Nivo or Ipli or Pembro with Axitinib or Levantinib with Pembro or Nivo with should be offered to these patients who have intermediate or poor risk. Pembro and Axitinib, or they can also be offered to patients who along with Sunitinib in febrile disc disease. Sunitinib or Pazo to patients with an IMDC who cannot receive or tolerate these immune when this, in cases of side effects which are not being tolerated by patient, you can replace them with these drugs. It's also strongly recommended to offer cabozantinib to patients with intermediate or poor risk MRCC who cannot receive or tolerate immune checkpoint inhibitors. And patients who do not receive a full course of ipilimumab due to their toxicity can be given single agent nivolumab, which has a weak recommendation, and re-challenging can be done after discontinuation and when the toxicity subsides. So sequencing is strongly recommended in these patients. It's not that you can give these drugs randomly. That has to be sequenced as first line and second line treatment. So this is the first line treatment for metastatic RCC. So in favorable risk category, as I mentioned, all of these 4 combinations or sunitinib alone when these combinations are not tolerated. And in poor risk combination, again, these can be given. As an alternative, cabozantinib or sunitinib or pazopanib can be given. When we come to second line therapy, where patients have already received TKI or immune inhibitors, cabozantinib can be offered with any VEGF target therapy. If there's only prior TKI, then Nivo or cabozantinib can be offered to this patient with an axitinib as an alternative. And belzutifan is patients who have received several kinds of treatment, including IOI and TKI. So this is the indication for that. Coming to the side effects, all of these treatments are affect the kidney. They have several side effects, systemic treatment about, but we'll just focus on the renal side effects. Many of them lead to renal impairment, but in most of the scenarios, you do not need to stop or discontinue these drugs for a longer time. They can be continued even in mild and moderate impairment of renal function. But for severe impairment, there is still no data because there is a lack of studies in patients who are on hemodialysis. There are just a few studies and smaller numbers. And many of these trials do not recruit, in phase C trial, do not recruit patients with a lower GFR. So we have a lack of data regarding those patients. But in other patients who are having mild to moderate dysfunction, these medications can be continued and have to be closely monitored. When it comes to nephritis, there is a grading from grade 1 to 4, depends on your baseline creatinine level. Or so the recommendation is that if there is just a grade 1 nephritis or impairment is not, or up to grade 2, you can still withhold CPI and for a shorter time and again restart these drugs later on. And apart from that, other adjunct measures like reducing other nephrotoxic drugs which may be going on at that time, improving the hydration of these patients, and maybe trying to, maybe giving a course of steroids to improve these patients. So many of these scenarios, these drugs may need to be stopped and monitored closely, and the patient can be re-challenged with these drugs once the toxicities are controlled. So the take-home message is that renal toxicities of these target therapies may be different in different generations, but they are usually mild to moderate and can be managed effectively if identified in time. The adverse event should not necessarily mean that you should continue these therapies, because that would affect their overall outcomes. So these can be controlled, and these risks can be mitigated by close collaboration between nephrologists and medical oncologists, and these patients can still be managed effectively. In conclusion, I would say that metastatic RCC and CKD require a very integrated approach, and multidisciplinary approach to tackle a problem which is quite challenging for both the urologist and nephrologist and medical oncologist. So a close cooperation between them is important. Newer field of nephro-oncology now is emerging, where nephrologists trained in identifying these adverse effects and managing them effectively.
Hello, Dr. Ola. Just get ready. We'll start within 3 minutes.
Now, as I mentioned, then the data is emerging that cytoreductive partial nephrectomy can be a viable option in some of these selected patients, but is still to find its place in recommendations. Now, in future trials, we can target the common pathways of both these entities and try to find better results. And the same that trying to stress the point that multidisciplinary approach is the best way forward for this challenging scenario. Thank you, everyone. Welcome.
Thank you very much, Dr. Zafar, for this wonderful presentation. Our next presentation is going to be virtual.
We'll start now.
From a prominent speaker from Nigeria, Dr. Ololekan Olowesi, and he's a Chief Medical Director of Zenith Medical and Kidney Center. He's a Master of Science in Transplantation Science and University of Liverpool in 2020, and a member of the Royal College of Physicians and Nephrology Fellow at the National Postgraduate Medical College Nigeria in Nephrology. Today he'll be talking to us about surveillance of malignancy in post-transplant patients. Welcome, Dr. Ololekan.
Thank you very much. And
Nephrology Fellow at the National Postgraduate Medical College Nigeria and Director of Zenith. He'll be talking to us about surveillance
Sound.
post-transplant patients. Welcome, Dr. Ololekan.
thank you very much. And
National Postgraduate Medical College Nigeria and Director of Zenith. He'll be talking to us about surveillance
Sound.
post-transplant patients. Welcome.
thank you very much. I want to first of all thank the organizers for inviting me. I feel very bad that I wasn't able to make the trip because of health concerns. Today, I'll be talking about the surveillance of malignancies in post-kidney transplant patients. I've got no conflict of interest, and there are no other declarations to make. Today, I'll be talking about the surveillance of malignancy. I bring you greetings from my center in Abuja, Nigeria. And then this is my outline. We'll be looking at, we introduce this topic, look at the epidemiology, and then we look at the reasons why surveillance really matters. And we talk about the pathophysiology and the specific risk factors of malignancies. How do we prevent, and then how are we going to be able to screen these patients? What are our surveillance strategies? And then we talk about the management and treatment, and we're going to conclude. Now, as a way of introduction, kidney transplantation remains the gold standard treatment for end-stage renal disease, and it significantly improves both the quality of life and the long-term patient survival. However, this success comes with a lot of problems. So it's more or less, there's a major trade-off in the way of a significantly elevated risk of developing malignancy. And so for that reason, cancer is now ranking number 3, the third leading cause of death in kidney transplant patients. And this has surpassed, this is only surpassed by the cardiovascular disease and infections. In fact, as a matter of fact, a lot of people, a lot of centers, especially in the third world, think that infection may come second. Now, this presentation will explore the rationale and strategies for effective cancer surveillance in this high-risk group population. Now, we'll be looking at a slide where we talk about the incidence of malignancies in kidney transplant patients is about 2 to 4-fold increase, is higher when you compare to the age and gender matched general population. Now, also, even amongst the mortality rates are higher in transplant recipients as against non-transplant patients with the same cancer. And these cancers are more aggressive, and this aggression is linked to immunosuppression that impairs the T cell function and then inhibits cancer immunosurveillance. And of course, the oncogenic viruses, which we know are also inadequate, though they are not able to control these viruses in the way of multiplication. These viruses will include Epstein-Barr virus, human papilloma virus, hepatitis B virus, and HCV virus, hepatitis C virus. Now, we are looking at a slide showing us the most common malignancies that we have in the post-kidney transplant patients. The non-melanoma skin cancers are of very high incidence, and of course, squamous cell carcinoma, quite common. And squamous cell carcinoma is actually the most common of them, as against the general population where basal cell cancer is the most common. Now, other prevalent types of cancers that we have in these patients are post-transplant lymphoproliferative disease, PTLD. PTLD, I must say, is the second most common malignancies in the post-kidney transplant patients in adults. In children, you have PTLD being the most common. And then, of course, colorectal cancers, renal cell cancers, Kaposi sarcoma, quite common. Now, the diverse nature of these cancers requires a multifaceted and vigilant surveillance approach. And then, of course, the picture showing us the various cancers and the various screening strategies. Now, there's a screening dilemma in post-kidney transplant patients. While cancer screening programs are well established for the general population, the optimal strategies for transplant recipients are not yet clearly defined. And that's why various transplant groups, various guidelines coming up with different protocols. But at the end of the day, we have quite a number of these groups agreeing on certain areas. There's also an increased risk and unique cancer profile, which will necessitate a more aggressive and proactive screening program. Now, the goal of this talk will be to review the evidence and outline rational surveillance strategies for the most common post-transplant malignancies to enable early detection and improve outcomes. Now, this is a slide showing us how high the incidence is. You can see a 2 to 4-fold increase in the risk of malignancies as when matched with age and gender. You can see the peak incidence is around 3 to 5 years in the post-transplant era, though this varies by cancer type and in recipient age. Now, the standardized incidence ratio is used to quantify this elevated risk for specific cancer types. And of course, the critical outcomes, cancer-specific mortality is higher in the transplant recipients than in non-transplanted patients with the same cancer, and of course, even after adjusting for stage and treatment. Now, the standardized incidence ratio, we can see here, the SIR of greater than 5, these are the most common cancers that we have in the post-kidney transplant patients: Kaposi sarcoma, non-melanoma skin cancers, post-transplant lymphoproliferative disease, kidney, renal cell cancer, vulvar cancer, penile cancer, anogenital cancer, liver, and lip cancer. It may interest you to know that the lip cancers are about 50 times, it's said that they are more than 50 times more common in the kidney post-transplant patients than the general population. Now, the group with standardized incidence ratio of less than 2 are the ones that have about the same incidence, with the general population: breast cancer, ovarian cancer, uterine, pancreatic, brain, and prostate. Now, we're still looking at the epidemiology, and then we look at the skin, the most common ones I said earlier on: Kaposi sarcoma. They are quite very aggressive. Multifocal and occurs in younger patients. Skin pathogenesis, you look at their risk from ultraviolet exposure, and of course, fair-skinned people. Then the primary human papilloma virus is detected in about 90% of squamous cell cancer cases in the post-transplant patients. Of course, immunosuppressive drugs are part of the problem, as azathioprine and cyclosporine have direct skin mutagenic and phototoxic effects in this set of patients. PTLD is the second most common. And of course, the incidence rate is about 1 to 3% of renal transplant recipients. In children, PTLD is, as a matter of fact, the most common malignancy in post-transplant patients. Now, about 70 to 90% of Epstein-Barr virus, 70 to 90% of these cases are EBV positive, while about 10 to 30 of the cases are EBV negative. Now, the ones that are EBV negative are of late onset, about 5 years post-transplant, most times. They are usually more aggressive and less responsive to reducing immunosuppression. Now, we look at why is surveillance very important? Why does it matter? Why do we have to do surveillance? Now, it is important because cardiovascular disease treatment has improved in post-transplant patients. We now have more medications, antibiotics, antivirals to treat infections. However, cancer has emerged as a leading threat to long-term survival in the post-transplant patients. As a matter of fact, it is now the third leading cause of death in kidney transplant recipients. Crucially, we are looking at transplant patients. They face a double burden in the sense that the incidence is higher. They are more likely to get, cancer when they are post-transplant. And then, of course, the mortality, even when they have these cancers, is even higher because they are more likely to die from it when you compare post-kidney transplant patients to non-transplant patients with the same cancer due to more aggressive disease and, of course, the comorbidities. Now, we're also looking at the challenge. Now, there is a very clear-cut guidelines for the standard population. But in the post-transplant patients, there isn't enough clear guidelines. Optimal strategies, frequency methods are still being defined in the various guidelines that we have. Now, the current practice is that many centers already proactively screen for high-risk cancers like skin, cervical, and colorectal cancers. Now, the goal of surveillance would be to enable early diagnosis at a stage where treatment, surgery, chemotherapy, radiotherapy is most likely to be successful and curative. Now, in conclusion, you will look at a structured surveillance program that is not just optional. It is an essential component of long-term post-transplant care in order to protect the gift of transplantation. Now we're looking at a weakened immune system, which is the cornerstone of post-transplant carcinogenesis, and is primarily through these three mechanisms. Now, the first mechanism is that there is impaired immune surveillance. There's loss of the ability for natural killer cells, dendritic cells, cytotoxic T cells to identify and eliminate virally infected or malignant cells. Now, there's also an uncontrolled oncogenic viruses. There is a failure to control viruses like Epstein-Barr virus, human herpes virus type 8, and human papilloma virus. And this directly drives cell proliferation and cancer development. Now, the direct drug effects, some immunosuppressants like the calcineurin inhibitors, azathioprine, directly inhibit DNA repair mechanisms. And this promotes tumor angiogenesis and enhance ultraviolet-induced skin damage. Now, this is just a slide looking at the various risk factors for post-transplant malignancies. For example, the non-melanomatous skin cancers, commoner in males, commoner in Caucasians, commoner in the elderly, and of course you have those who have also commoner in the pre-transplant patients with skin cancers history. And then, of course, the human papillomavirus infection is a risk factor. Ultraviolet radiation exposure is a risk factor, with ultraviolet B being more oncogenic than ultraviolet A. Immunosuppressives like azathioprine and cyclosporine use increases the risk of this cancer. Azathioprine, for example, increases the risk of squamous cell carcinoma. Now, PTLD, we all know the role of Epstein-Barr virus infection and cytomegalovirus infection, the role they play. And of course, the risk factors are also young age, serodiscordant EBV status, in the sense that you have donor being EBV seropositive and recipient EBV seronegative. That increases the risk. Of course, the use of belatacept also increases your risk of PTLD, and the use of lymphocyte depleting induction therapy like rabbit-HEG. Now, Kaposi sarcoma, the risk factor here is the oncogenic virus, human herpes virus type 8 infection. It's quite common, and you will see in my several slides that I'm going to project. Renal cell carcinoma has risk coming from when patients are on long dialysis vintage, they have acquired cystic diseases, autosomal dominant polycystic kidney disease, analgesic nephropathy, toxic nephropathy, and obstructive nephropathy are all risk factors for developing renal cell carcinoma in the post-transplant era. Now, bladder cancer, we know the association with BK viral infection, while we know the association of hepatocellular cancer with hepatitis B and C infection and alcoholic liver cirrhosis. Now, this is still a slide showing us the various risks and the factors associated. I will skip. Now, we're looking at it in another form, the modifiable and non-modifiable risk factors. We mentioned them for high risk, lymphocyte depleting induction agents, ATG, and lentusimab doesn't really it's not clear because a lot of people think it doesn't increase the risk of PTLD. Now, the high dose calcineurin inhibitors, when patients have to be on high dose, the risk carries high risk. I mentioned earlier on that azathioprine is photocarcinogenic, and then it carries a high risk for non-melanoma skin cancer, precisely squamous cell cancer. mTOR inhibitors, sirolimus and everolimus, are associated with lower risk of skin cancers and Kaposi sarcoma. Note, the trade-off with higher mortality from other causes. Now, for viruses and other key factors, we mentioned these viruses: Epstein-Barr virus, human herpes virus type 8, HPV, and other factors like UV exposure and acquired cystic disease, which is a significant risk factor for renal cell carcinoma in the native kidneys. Now, this is just a summary of what I've mentioned and the various risk factors that we have. Now, we are looking at the pathophysiology and the risk factors. We mentioned that the various guidelines, KDIGO guidelines on waiting times, for example, there is no need for waiting for low-risk tumors like localized basal cell cancer. And then, of course, if you have an incidental finding of a renal cell cancer of less than 1 cm, these patients can proceed to have kidney transplantation. Now, there's a 2-year waiting period for most cancers in remission. However, when they have, for high-risk cancers like the ones with advanced stage or invasive cancers, you may have to wait for 5 years. Now, there is an absolute contraindication to transplantation if you have an active cancer or untreated cancer at the time of transplant evaluation. Those patients will have to be taken off your waiting list. Now, surveillance strategies. It's a two-phase approach. You have the pre- and post-transplant strategies. Now, the goal is to minimize cancer risk and ensure early detection through structured vigilance at all stages of their care of these patients. Now, the pre-transplant folk will focus on careful candidate selection. You have to select your patients, and then, of course, you screen to avoid transplanting into active or high-risk recurrent cancer. While the post-transplant phase will focus rich stratified proactive surveillance to detect malignancies at their earliest and most treatable stages. Now, the first line of defense is to look at, to talk about history and the physical exam. These patients are meant, for example, skin cancers. Then, of course, the risk-based screening, where you do their blood work, chest X-ray. The high-risk patients will need abdominal ultrasound or CT, and then those with history of analgesic use, smoking, or acquired cystic disease to rule out native renal cell carcinoma. Now, we're also looking at, this is a slide just showing us the various guidelines, our expert opinion for skin. They think is 6 to 12 months total body examination either by the dermatologist or the physicians on a 6 to 12 monthly basis is appropriate. And these are the screening recommendations. And the various groups, KDIGO, American Society of Transplantation, the Canadian Society, they all agree that this is the way to go. Now, for adults aged 55 to 79 years, every year they are expected to have a CT, low-dose CT scans for those who have smoked more than 1 pack per day for 30 years or is equivalent. For breast cancer, we've mentioned earlier that the SIR is quite comparable to the general population. For women aged 50 to 74 years, screening mammography once every 2 years is recommended. For liver, for those with cirrhosis, routine screening using ultrasound with or without alpha-fetoprotein levels every 6 months is recommended. For kidney, there is no routine screening for renal cell carcinoma. Ultrasound is not recommended for all patients of transplant, except for high-risk individuals. Now, for the colorectal cancers, for adults aged 45 to 75, fecal occult blood, then biennially, you do a sigmoidoscopy every 5 years, and of course, colonoscopy every 5 to 10 years. Most of the guidelines agree to that. Now, for cervical, annual pap testing with HPV testing every 3 to 5 years, starting at the age of 25 years until 74 years. We know that for prostate, for men, 55 to 69 years, screening decisions should be individualized. It's not a general term. And then for men greater or equal to 70 years, should not be routinely screened for prostate cancer. Now, what are the gaps? Lung cancer, consider annual CT chest for recipients who have had, like I said, greater to 20 pack years smoking. And then, of course, we look at other factors like avoiding excessive immunosuppression, use the minimal effective dose to maintain graft function. Now, sun protections, there are various sunscreens, creams with high sunscreen factor, with sun protection factor, some protective clothing like, then of course, there are some caps that are used that will help, and then avoid coming out during the peak periods, midday, 1 hour before and after midday. Now, vaccination is important. Administer human papillomavirus vaccination before transplantation, whenever possible, for optimal efficacy. It is also safe post-transplant, but may be less effective. Now, lifestyle modifications, smoking has to stop. The screening rationale aims to detect precancerous lesions or early-stage disease to prevent progression to aggressive malignancies. Now, this is also looking at the various cancer type and who you are going to be screening, the modality I've mentioned earlier on. Same thing, still talking about the various cancer types. Then we're looking at, for colorectal cancer and renal cell carcinoma, which we mentioned, monitoring, how do we monitor and how for PTLD prevention. We looked at
please, Dr. Ola.
Yes. Now, we're looking at the cornerstone of management would be to reduce or modification of immunosuppression is the first step And then, of course, the goals will be to restore some host immune competence for cancer surveillance. And then the approach will be reduce or stop anti-metabolites, reduce carcinogen inhibitors dose, and then, of course, to switch to mTOR inhibition. This is also still talking about the various treatment modalities, surgery, radiotherapy, and chemotherapy. And this is a slide showing us the waiting period for the various cancers, which I mentioned earlier on. Now, this is a stepwise approach to treating PTLD in these patients. Rituximab anti-CD20 plays a role for the treatment of PTLD. Now, this is a study from our own center, which was published in 2019, where these are the two cases that we saw with, we reported with Kaposi sarcoma. As we all know, we earlier on said that it's quite common. And then you can see the CT showing para-aortic lymphadenopathy and diffuse hepatic nodules in our patients with KS. At one point, we thought we were dealing with a lymphoma, but eventually we made this diagnosis, and this patient did so well with switching from CNIs to sirolimus. Now, what are the future directions? Safer immunotherapy. We were looking at developing novel immune checkpoint inhibitors, which we think will be useful. And of course, personalized risk stratification, advanced
Thank you, Dr. Ola.
and chemoprevention.
Actually, please, can you come to the conclusion?
In conclusion, this is our new transplant complex that will be opened first quarter of 2026. And then, of course, in conclusion, I would say what you do makes a difference. I'll give you the scope, and you have to decide what kind of difference you want to make. By Jane Goddard, a British dermatologist. Thank you.
Thank you, Dr. Ola, for your elegant lecture. Now
Thank
coming to Chairperson, please.
You want to make Jane.
Thank you, Dr. Alatis, for this fruitful lectures. Now to the next speaker, my colleague and friend, Dr. Ala Sheikh Ali. He's a consultant nephrologist and transplant surgeon. He's the head of the medical department.
Thank you very much. It was a very nice lecture.
Transplantation Center at Medical City in Baghdad.
Thank you.
He currently serves on the Transplantation Society's Education Committee. He is the Vice President of the MESOT and contribute to the International Society of Nephrology online education team as an ISN Middle East Regional Board member.
Oh, okay.
Dr. Ala, we talk about
the presentation was
immune
good.
checkpoint inhibitor associated nephrotoxicity.
Thank you.
Challenges and
That was a nice one, sir.
Dr. Ala,
Thank you.
Thank you, Mr.
Where is,
Chairman. Bismillah
Harry?
ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa
I think
barakatuh.
the questions will
First of
come
all,
at
I
the
would
end.
like to thank the organizing committee, Dr. Isa, Dr. Amr, and all many colleagues for the kind invitation. I think you have a lot of cancer data in the previous presentations, so I would like to entertain you with the last presentation. So can I have my slides, please?
Oh, wait, okay.
So my task was to
actually
talk about
see you
evidence,
physically,
challenge, and the road
and
ahead with immune
inshallah,
checkpoint
we'll see you again.
I have
Thank
nothing
you.
to disclose from
Thank
the
you.
financial point of view, but from the scientific point of view, I would like to share with you that I was involved with the ASN in
Questions?
publication of these two